We will start at 4 or Matthew sir? 3 minutes left.
Dr. Millet is there?
He's just joining. I just spoke to him.
You know, check his lens.
Good afternoon, everyone. Dr. Matthew.
Ah.
From minus 27 to 30. Huh?
You were in Siberia last.
Yeah.
Maybe 1 week back.
Yeah, I'm not in Mumbai. So I'm outside. So that's why I was just, you told me like I'm traveling. Yeah, I'm traveling. I'm there.
Yeah.
Hi, Dr. Badu, how are you?
Good
Where
afternoon.
are you seated?
Good afternoon. Pardon?
You are sitting in some temporary shed-like place.
Pardon?
Right now, where are you? Right now, where are you?
Where are you?
I am in Bangalore.
Okay.
Okay. You look like you are sitting in an outhouse.
Yeah.
In the background, there are some stand for thunder.
Yeah. So, yeah. So we are starting, no? We'll just...
We'll start in
mine
1
is the
minute.
third talk, no, Rajesh?
Yes.
Yeah, yours is the third talk.
Okay.
Most people join a little late. Hello, Dr. Falak.
Hi, Manoj. How are you?
Good evening.
Yeah, good evening.
I think we can start now.
Yes, sir. I think we can. So, am I audible, sir?
Yes,
Yeah,
sir.
you're audible.
Yeah. So, good evening to all joining us from various corners of the country and abroad. My name is Dr. Sachin Jose Pudikal. I am a neurosurgery consultant working at Lizzie Hospital, Kochi, Kerala. I am honored to serve as the coordinator for today's webinar. As we know, the topic for today's discussion is management of acute ischemic stroke. It will cover key aspects of acute ischemic stroke management to ensure that we are all equipped to deliver the highest standards of hyperacute care in this very important health condition. The session will consist of 4 talks, and each speaker will get around 20 minutes for each presentation. And I have the privilege of introducing the moderators for today, Dr. Jayesh and Dr. Matthew. Dr. Jayesh serves as the director of minimally invasive brain and spine surgery at Fortis and Mullins, Mumbai. He is a specialist in endoscopic brain and complex spine surgeries. He has numerous publications, 2 books, and even a patent to his name under his name. And he is an ex-faculty of SGPGI Lucknow. He is also the current chairman of Young Neurosurgical Forum NSI and Innovation and Potential of the NSI, and is also editor of the Journal of Spine Surgery. Welcome, sir, to the webinar.
Thank you, Sachin, for the nice word.
I would like to invite Dr. Matthew, who is currently the head of Department of Neurosurgery at NSI Hospital, Kochi. He has been a faculty at Sri Chitra Institute since 2003 and was HOD of Neurosurgery from 2017. And he is currently the HOD of Neurosurgery Department at NSI Hospital from 2022. He has keen interest in complex cerebrovascular surgery, skull-based surgery, and epilepsy, and has contributed more than 100 papers to numerous national and international journals. He is the current convener of the webinar committee as well as an executive committee member of the NSI. Welcome, sir, and thank you for joining us this evening.
Thank you, Dr. Sachin.
Yeah. So I invite Dr. Jayesh and Dr. Matthew to introduce the panelists for today. Over to you, sir.
Sir, shall I start, Dr.
Yes,
Matthew?
sir.
Yeah. Please.
Yeah. So, welcome all to this wonderful webinar. Today's topic, the management of acute ischemic stroke. It's very, very essential in our practice, not only for neurologists, neurosurgeons, in all the aspects. And to discuss, we have, it's my absolute honor to invite our chairperson, Dr. S.K. Gupta. And it's my privilege to introduce. He's a professor and HOD at PGI Chandigarh with a legendary career spanning of 32 years. And he is an absolute Indian titan in neurosurgery communities. He's previously served as a president of Skull-Based Surgery Society of India, as well as Neurotrauma Society of India, and he's represent the country on WFNS Skull-Based Society Committee. He is also a representative of International Meningioma Society of at World Federation. He is a past executive member of NSI, a faculty for NSI educational course throughout the India for more than 2 decades. It was very popular and includes various webinars. So there is a master of surgical innovation, has mentored generations and neurosurgeons through the state of art skill labs. I am one of the big fan of sir, and we are honored to have his expert perspective in our panel today. Thank you, sir, Gupta sir, to being here.
Thank you, Yesh.
Matthew sir, can you?
Yeah, I'll introduce Professor Padma Srivastava. It's an absolute honor for me to introduce our distinguished panelist, Dr. M.B. Padma Srivastava. She's a prominent figure in Indian neurology and currently chairperson of neurology at Paras Hospital in Gurgaon. She was serving as the head of the Department of Neurology and the Chief of Neurosciences Center in All India Institute, New Delhi. She has been in that position. She has mentored generations of neurologists, and she was a pioneer in stroke treatment in the country. She has established the first code stroke program in the public sector in India and has also mentored a huge number of neurospecialists in giving acute care for stroke. She's a recipient of the prestigious Padma Shri Award, and she is extensively published, and she's a much sought after speaker at a national level. We are privileged to have her world-renowned expertise in our panel to discuss the complexities of stroke management of today. Thank you, Madam, for joining us.
Thank you so much. It's an honor to be amongst this galaxy of neurosurgeons. I'm actually a lone wolf out here, but it's a real honor. Thank you.
Thank you.
So, with the permission of Chairman Gupta sir and Padma Madam, shall we start the speakers and the talk?
Yeah.
So first, I would like to invite Dr. Deep Das. Let me introduce about Dr. Deep Das. He is a dean neurologist. He's a leading interventional neurologist in Eastern India, specialized in acute stroke therapy. He's pioneered the use of advanced stroke thrombectomy and thromboaspiration in Kolkata. Is currently serving as a consultant at CMRI, that is a Kolkata Medical Research Institute, BM Birla and Woodland Hospital. He is in core competencies in intervention, all kind of thrombectomy and coiling and carotid stenting, more interested in stroke. And he's a principal investigator for the grassroots trial in Eastern India. It's leading to the commercial licensing of the Supernova standard driver in India. It's very, very interesting. And he's the author of 20 national and international publications and multiple book chapters on neurointervention and stroke care. Now, today we'll learn from him about the decision making in acute ischemic stroke, guidelines and dilemma. Sir, welcome, and you may share the screen.
Thank you so much. So it's a privilege being with the stalwarts and one lone wolf. Okay, at least I don't consider myself an wolf. Madam Srivastav is a mentor, and it's an honor sharing the same virtual platform with her. Thank you for the invitation. So, acute ischemic stroke, we all are aware of. We don't need too much to understand the syndromic pathology and when we should suspect a stroke. So I think we all know that. The problem with the Indian scenario is that we are serving our stroke patients out of a various myriad sort of platforms. Like there is the public platform, there is a private platform, there is an organized sector, there is an unorganized sector, and stroke itself is very diverse in its presentations, and no single bullet can cure this disease unless we have some sort of a homogeneous approach to the diagnosis, and at least follow some sort of homogenized approach towards each stroke patient. It will not cover every patient, but for the majority it will. And we also need to move out of our own comfort zone. That is what I feel. As a neurologist, we are often more into academics and leave the hard job to our colleagues, neurosurgeons, radiologists. But if we are to treat truly our patients who are suffering from stroke, we also should actually come out of our shells and start working a little more focused and gain some sort of skills which are not taught to us in our own DM curriculum. So that is one thought, because the final aim is to serve a patient who is in acute need of therapy, which is sometimes life-saving. So can I have the second slide, please? So the burden of stroke in India, it's a demographic challenge. Now, why it is a demographic challenge? If we see that India is doing very good in terms of its GDP. It is striking a lot of new alliances with the rest of the world, and we are moving ahead, forging ahead. But if we analyze our demography, then it is mostly based out of the young population that we are currently having. So stroke is something which is now consuming or affecting a major chunk of this young generation. So people in their 40s, in their 30s are also having classical stroke syndromes, which were taught to us that they will happen after their 60s. So various sort of lifestyle problems, various sort of stress. So these are affecting the young generation as well. And since a person who is in his 40s will at least have another 20-25 years of his productive life, if he or she suffers from a stroke at an early age, then what will happen is that if that person does not pass away, then there will be a lot of disability which he or she will carry throughout the rest of his or her life. And that will also affect not only the person per se, but also the immediate family and the healthcare system as well. So we must understand that we have to be more proactive in recognizing the stroke and triaging those stroke into the proper facility. Like every suburban nursing home won't be able to give the patient a thrombolysis or a thrombectomy at the most appropriate hour. So triaging of those patients are very important, and throughout the country, it should come as a national policy where any stroke network should be established. This is very essential actually. So I think logistical barriers need to be overcome. Pre-hospital delays due to traffic and lack of organized emergency medical services really hamper the actual delivery of the stroke therapy. Now, coming to the economic constraints that we all face, that not everybody is privileged to go to a cutting edge technology center to avail the best of therapy that we can provide. So the standard of care needs to be spread out throughout the country, throughout the suburban health centers. Any center which have a city must be empowered to also have that knowledge and practice attitude to at least dole out thrombolysis. So that is very important. In West Bengal, the government is actively doing a stroke program through telethrombolysis. And till date, I think we have done more than 1,400 thrombolysis in the last year itself. So that model is working, that can be done actually when implemented in a larger scale. And the goal ultimately would be to bridge the gap between the tier 1 comprehensive centers with aligning them with the rural primary stroke centers. So that gives you a better stroke net coverage, which will bring everybody under the same treatment protocol and as much as possible to give them the best therapy at that pertinent hour. Because you know that stroke has a golden hour. We cannot wait for stroke thrombolysis or thrombectomy to happen. Can I have the second slide, please? So now we will delve briefly into the hyperactive clinical assessment. How to assess a stroke? So this is best dealt by the BFAST. So we all know that what is BFAST. BFAST is a very catchy and short acronym where B stands for balance, E is for eye or the vision, F is for face, facial asymmetry, arm is for the hand or the leg weakness, speech is of course for the voice. And when we have isolated or a conglomeration of these signs and symptoms, we do not waste T or the time. So be fast. I think this again is many a times we are discussing this in a platform where possibly every one of us know what is be fast, but it needs to be generalized and spread among the masses. So this is some sort of vaccine that works in hours of crisis and need. So I should actually invite each one of you to be an ambassador of stroke, and whenever you are counseling or seeing some patient of stroke, at least spread the word of be fast among the stroke survivors and the relatives who usually accompany them in various social gatherings that we attend. So this has to be followed with a zeal. Unless education and attitude changes, we will not be able to cater to the stroke patients as well we should be. And any number of innovations, any number of new drugs are not going to help because we are not going to get our clients in the proper time and place. So stroke, you will all be aware that these are basically divided will be into large vessels or small vessels. Now, when it is a small vessel stroke, it is more or less dealt in a uniform manner. But for large vessels, which are the killer ones, we have to have some index of suspicion at the very beginning that, well, this is a large vessel occlusion and possibly this patient will require urgent and immediate attention. So here the NIHSS acts as a biological marker for that. So any NIHSS score which is more than or equal to 6 has a very high probability of a large vessel occlusion. By large vessel occlusion, we would be meaning the ICA or the MCA or the basilar. So initial imaging, of course, the gold standard is a CT, which is very widely available in now. In any mohallas, in any small centers also, we have a CT brain. So once the CT brain is done, what immediately happens is that we rule out hemorrhage. So a patient with a stroke syndrome without a hemorrhage has an ischemic stroke. So that is what we should understand and what we should practice. So a normal brain does not mean a normal patient and a normal vessel. So once there is no hemorrhage and a stroke syndrome, this is a ischemic stroke. And from there on, time becomes paramount importance because every minute leads to loss of 1.9 million neurons. When translated, it leads to loss of function, loss of memory, loss of speech, and an individual who will become dependent by the minute. Can I have the second slide? Now coming to the agents which can be used to reverse this condition. So now in India, tenecteplase is the molecule that we are using. What is the advantage of tenecteplase over the RTPA that we earlier had? There are 2-3 major advantages. One is a very short delivery time. So this is given as a single bolus, which is 5 to 10 seconds. So you fire and you forget. Whereas in RTPA, you have to use this as a 1-hour infusion. So carrying a patient with a infusion along with throughout the hospital, through various imaging procedures, through to the cath lab becomes a problem. Even transport becomes a problem. So this is a single shot delivery, and that is the beauty of this molecule. It also has a superior pharmacokinetics in that it has a very high fibrin specificity and a longer half-life than alteplase. It also has a property of opening up the large vessel occlusion to a larger extent than alteplase. So this works always better also in cases of large vessel occlusions. And for the drip and ship model, where the patient is given this molecule in the periphery and has to be transported to a higher center, this is also a very convenient way of treating the patient. So the dosage, as you will know, is 0.25 milligram per kg and given to a maximum of 25 milligram for a 100 kg patient. The next slide, please. Now, who are the candidates who can and will benefit from mechanical thrombectomy? So we have identified a patient with a large vessel occlusion through a NIHSS score of more than 6, through a CT angio or a MR angio which shows large vessel occlusion. Now, not all patients with this criteria will be benefited. So in a resource poor center or a resource challenged center, we should sometimes be pragmatic about the choice of patients. Though stroke is now treatable till 24 hours, some people advocate treatment of every large core infarct. In our routine daily to daily practice, we usually try to avoid patients with a very large core, because even when you open up the vessel successfully, very elegantly, the brain tissue is damaged. You cannot actually achieve what you aim to achieve through opening up of these vessels. These are costly procedures. So among the clientele that you will have, we have to have the peak of these patients who will be likely to benefited to a large extent through mechanical thrombectomies. So again, just remember a rule of 6. So we have earlier discussed that NIHSS more than 6 tells us of the high likelihood that this patient will have a large vessel occlusion. Now, if we come to the next 6, which is an aspect score, then aspect more or equal to 6 tells us that at least 60% of the MCA territory is salvageable if we can open the vessel at that point of time. So a large chunk of brain tissue surviving, and we are saving those brain tissue, and that translates into a better result. And onset of time less than 6 hours. So there is a lesser propensity of the brain to get damaged in an early window period. So 6 is the word to, or 6 is the figure to memorize, that NIHSS is more than 6, aspects greater or equal to 6, and time less than 6 hours from the onset. So these are the best subset of patients that we can treat for an LVO. And obviously the patient has to have a LVO confirmed on a large vessel occlusion, either on CTA or MRA, or the clot must be visible even on a plain CT scan, which sometimes it does. The next slide, please. So mechanical thrombectomy has now become the standard of care for large vessel occlusions. Now, we all know that what is the procedure? It's a simple procedure where the endovascular clot retrieval is done either using stent retrievers or large bore aspiration catheters. These will all be elegantly dealt by the later speakers, I'm sure about that. So what is the superiority of the process? Now, a large vessel will contain a large amount of thrombus. So this large amount of thrombus will be resistant to the lytic effects of the IV medications that are likely to reach there in less proportion as compared to the small vessels, like a M3 branch or a P3 branch. So cortical vessels are more amenable to be opened up by lytics, whereas proximal large vessels are more resistant to lytic effect. So here, the superiority of the mechanical thrombectomy stands out. And in cases where the patient has already received a thrombolytic agent like tenecteplase, it is even more evident that mechanical thrombectomy likely is to be more successful in such cases. In the Indian context, increasing availability in private and specialized government sectors focus on reducing the door-to-puncture time now becomes very important. Now, we have to have more facilities where mechanical thrombectomies are carried out. And mechanical thrombectomy does not require a very hi-fi neuro-specific lab. It can be done in a cardiac run-of-the-mill machine also. But we need to have ourselves acclimatized to that situation. We have to have the team ready at that hospital and a team of anesthetists who can help, a team of intensivists who will take care of the patient post-MT. So this cath lab is now available throughout India, even in Tier 2 or even Tier 3 cities, courtesy our cardiology colleagues. So the training should be there and the awareness should be there. I think that will fill a major gap which is existing now. The next slide here. So we are just discussing about the Indian scenario and the decision algorithm. So we can divide it like this. From a patient coming to the ER arrival, it's a clinical examination and a plain NCCT brain. Any eligible patient is not to be denied the privilege of getting IV thrombolysis. The agent is tenecteplase, and if there is no contraindication, please give tenecteplase. Third, vascular imaging, which can be done at the same setting. We do a CT angio, and the coverage should be from the aorta to the vertex. If the patient now is within the triage of 6, if the rule of 6 is met, we should transfer the patient for MT. Obviously, the consent has to be there, the understanding has to be there, and we should not wait for the tenecteplase to act for, let's say, 1 hour. We should wait and then see whether the patient is improving or something. At best or at worst, what we will find is that the vessel has opened up and we will be very happy. If the vessel has not opened up with tenecteplase, we can open it up with mechanical thrombectomy. And by following an earlier rule of time, we are saving the brain. So post-procedure, this is very important. I think will be taken care of by the later speakers. The observation and the stabilization in the stroke ICU. The next slide. Now, just a brief discussion about the advanced imaging and the extended windows, because there will be late arrivals to our specialized centers, people who are dropping in from the rural areas, who have been referred from the rural areas. Here, the 6 to 24-hour window still holds. As we will know that the damage the brain suffers is 100% dependent upon the status of the collaterals. Now, if the collaterals are good, even a blocked ICA can be a silent phenomena. You just discover it on a routine basis. Whereas, if the collaterals are bad, a single MCA occlusion can lead to a major catastrophic stroke within 30 minutes. So those patients who are arriving late and has a good functional grade, I think they are having the privilege of having very good collaterals, and they should be taken up very urgently, and they should be given the benefit of thrombolysis, thrombectomy, whatever. So tissue window is a very important concept to understand. Collaterals good, the tissue remains good, the core is small, the penumbra is much more, the mismatch is much more, and we can salvage these patients. So here also, tissue clock versus time clock is an important concept to understand. the DWI flare mismatch or CT perfusion to find the ischemic penumbra becomes important for the late presenters, more than 6 hours. Practicality. In India, MRI is often more widely accessible than automated CT perfusion software in suburban centers. So, understanding the diffusion flare mismatch and the flare clinical mismatch is also very important to salvage these patients. The next slide. Now, a brief word of caution for the contraindications and the safety management. Now, exclusions, there are a host of exclusions, bunch of exclusions, which we encourage our juniors to memorize and write on the sheet of examination papers. I strongly discourage that, and we should only limit our exclusions to these few things: active internal bleeding, recent major surgery, or severe coagulopathy. Anything else is not a contraindication. BP targets must be less than 185 over 110 before tenecteplase, which is achievable in 99% of patients with labetalol, and it should be also kept strictly below 180-115 millimeter of mercury post revascularization. So that is also something which we can achieve very easily. Complication watch, early detection of symptomatic ICH, which might happen even without thrombectomy, even without thrombolysis, and yes, to a certainly enhanced extent with both these things, either thrombectomy or thrombolysis can lead to some patients having bleeding, but that might or might not be related directly to the procedure or the IV drug administration. So it should not become a taboo that, okay, we have used this drug and the patient has bled. There are innumerable occasions where nothing has been given and yet the patient is bleeding. The next slide. So to conclude, I will just take the opportunity of presenting the last slide. Summary: tenecteplase is the practical choice for Indian logistics, and rule of 6 simplifies the candidates for the mechanical thrombectomy selection. System of care, strengthening the hub and spoke model is absolutely essential in an Indian scenario to ensure rural patients reach MT capable centers. And AI will come in a very, very big way for triaging these patients. And there is a huge stake for the government to play in either the state level or in the central level for ensuring that these patients get the same facility as a road traffic accident patients in the availability of the government insurance like the PMJ for mechanical thrombectomy, hardware reimbursements, and their treatment. Thank you so much.
Thank you, Dr. Deepdas. Our next speaker is Dr. Milan Delapara. Dr. Milan is a consultant interventional neuroradiologist and peripheral vascular interventionist based in Ahmedabad, Gujarat. He did his MBBS and MD radiology from BJ Medical College, Ahmedabad. Subsequently, he did his DM neuroradiology and interventional radiology from Sri Chitra to Bangalore. He has fellowships from KEM Hospital, Mumbai, as well as AIMS, New Delhi. Since then, he has been practicing in Ahmedabad. He's a pioneer interventional neuroradiologist in Ahmedabad and is the first interventional radiologist to establish a private practice in the city. Additionally, he serves as a director and co-founder of Dave Hospital of Vascular and Interventional Radiology, the first of its kind NABH accredited independent interventional radiology hospital in specialized hospital in Gujarat. He has authored numerous papers in his name in various journals. His key areas of expertise encompass all neuro and spinal interventions, including ischemic stroke, carotid and intra-arterial stenting, subarachnoid hemorrhage, central venous thrombosis, spinal arteriovenous shunt embolization, and preoperative embolization of spinal tumors. He will be speaking on radiology in acute ischemic stroke, current protocols of imaging. Dr. Biren can share yours.
Thank you. Thank you for such a nice introduction, and thank you for allowing me to present here. So, can you hear me now? Hello?
Yes, yes.
Yeah, you're audible. You're
Okay,
audible.
okay. So, I will be presenting radiology in acute ischemic stroke and protocols of imaging. This was what I was told to present. So, I will just go through what is the aim of imaging in acute stroke and how CT and MR both can help us to uh, to get the answers which we are seeking in such cases. So if we go in basics, or if the patient you are suspecting clinically that he has ischemic stroke, so first thing we do a imaging to rule out whether it is ischemic or hemorrhagic, and for this diagnosis it is very helpful. So once the diagnosis is confirmed, the imaging we need to seek another informations like how is the parenchyma, how are the vessels, what is the site of occlusion, to decide whether reperfusion or recanalization is required or not required. So these two answers basically we want from the imaging point, which we both can get from CT and MR. As such, there is no standardized protocol which exists that we should do this. But based on whatever is available, means CT is available, if CT perfusion is available, or if MR is available, MR perfusion is available. Depend on that, we can decide what we should go ahead and what we should plan and how we can interpret so that we can make the decisions on that point. So basically, when we do imaging in acute ischemic stroke, we seek answer for these four patients. First is there any hemorrhage or not? Okay. So it's a hemorrhagic stroke or ischemic stroke. This is the basic question we see, as the previous speaker told, that we will do NCCT, and if there is no hemorrhage, we consider it a ischemic stroke, and then we we can give tenecteplase directly. So that is a basic primary question which we need to answer. Second question is, what is the size of infarct score? Is it a small infarct like lacular infarct, or it is a complete hemispheric infarct? And whether whether it is salvageable or not. Third question is site of vessel occlusion, means whether it is a small vessel occlusion, whether it is MCA or ICA. And fourth question, which is very important, is whether any salvageable parenchyma is present, means whether recanalization will help or it is totally futile. So these four questions we need to answer, and both CT and MRI can provide answers to these questions. So I will just go through that. Coming first, we will discuss about CT scan. So if we there is a CT scan in stroke imaging, we do it first CT. We rule out hemorrhage, and then we do CT angiogram plus delayed run, so that we can know the site of occlusion and more about the ischemic core. And third thing which we can do is the CT perfusion if it is available, and if the patient present late. So coming first to NCCT, the first question to rule out hemorrhage, in which normal non-contrast CT scan is very sensitive and specific. 86% sensitivity and specificity up to 98%. So it is very reliable thing, and it's universal, and it's a easy thing to rule out. Now, second question, which is more important, is ischemic burden. Now, for that, the aspect score is run in anterior circulation. We can see that in anterior circulation, marker. Do we have mark?
Yes, marker is visible. You may have to.
Can you activate that?
You have to do it from the PPT, sir. Or you can go out of the slideshow. Now the marker is visible.
Now
That's
marker is visible, but in slideshow it is not. But your slide is big enough to be seen.
I think that's you can now use it.
You
That's
can use.
we are able to see your marker. Yeah.
Yeah. It's that once we but play, it is not okay. It's okay. Now you are able to see, no? It's okay.
Yeah, yeah.
So
we can
we
see.
so expect score. As we know that there is 10 points total. One from caudate, one for lentiform, one for internal capsule, one for insula, and the three for MCA territory, anterior, middle, and posterior. And this is at the basal ganglia level, and this is at corona radiata level. And if we see any hypodensity, we keep on minusing one for each of these territories. Usually 0 to 2. If expect score is 0 to 2, it means it is a very large infarct and there is no trial and no guidelines, which if 0 to 2, we should not reopen the artery. Okay, this is a no thing. If it is 3 to 5, then, if it is a patient is usually within 6 hours, then still the new guidelines tell that we can still open the artery. But if it is more than 6 hours, then there is a restricted patient which may benefit if it is a 3 to 5 expect score. And 6 and more up to 24 hours, now new guidelines say we should open the artery. So this is so story is very important. Coming to posterior circulation, each thelema is given one score, occipital lobe is given one score, cerebellar hemisphere is given one score, two to midbrain and two to bones. Now, here CT is not very helpful in posterior circulation. So MR is only to decide whether what is the damage and how we should proceed further. MR is much better in this posterior circulation. So what is a basic of expect score, that why NCCT detect the ischemia delayed? Because NCCT depends on in ischemia cytotoxic ED markers, and so the water content increases, and increase in water content should be enough that it decrease the HU unit so that our eyes can detect it. So increasing 1% of water content decrease HU by 2.6, and our eyes can only recognize it if it up to 8 HU has been decreased. So it takes up to 1 hour to 45 minutes minimum to detect the changes in NCCT, and also sensitivity is low. But if we see that hypodensity in NCCT is specificity is very high, and also the hypodensity in CT is usually non-reversible. It is a already impacted non-reversible tissue, even if after we recanalize the artery. Doing imaging, you should not take this 1 mm cuts. Now 0.625 cuts are also available, but we should not interpret this aspect score on this. At least 3 to 5 mm cuts are required, and lesions should be available seen up to 2 cuts. And if any doubt, you don't consider it as a abnormal. Okay. So this I told that it is a lesion. If seen, then it's a non-reversible, and if it correlate with stroke severity and risks of symptomatic ICH. Now this is a new imaging CT angiography source image expect score. So what is it that when we do CT angiography and we do one delay cut also, then we are able to see the perfusion of the brain, and region showing this lack of enhancement, it is very much correlative with the CBV which we do on CT perfusion. So what is advantage? It is very sensitive, very highly sensitive than NCCT. It may also detect smaller infarct which are not visible on plain CT. Plus, it may detect early changes. Okay, so it's ability to detect early changes. It's almost approaching diffusion weighted imaging. So it can detect very early changes when NCCT is normal. Also, it is much better correlate with final infarct volume. Like it's similar to diffusion or CBV in correlating with the final infarct volume. And it also gives good detail of collateral circulation. Means if collateral circulation is good, then there is a good chance that if we recanalize, then patient will improve. So limitations are small ocular infarcts. We will miss on this CTSI, and also in posterior circulation, it is not a very good reliable thing. And uh, important is it is timing. If we do the cut very early, then it may overestimate, and if it is very late, then it may underestimate the impact. So timing is also important. But overall, it is much better. It will detect early lesions, and it is more correlating to the final impact volume. So this is the example. This is NCCT. Subtle hypodensity is same, but on CT ASI, we can definitely see the hypodense lesion. And this is a CBV map which is showing hypodensity. Similarly, same another patient. This is the plain CT. Cortical is not intense is also there. There is no hypodensity seen over here. So it's a not at all. It's a very early thing. But in same patient, CTASI is showing large area of hypodensity, MC occlusion, which is very much correlating with the diffusion weighted imaging and the final infarct size. Okay, so if we compare these two, we can definitely see that STSI is much more reliable than NCCT. Now coming to third question, site of vessel occlusion. NCCT may sometimes show hyperdense MC sign, and it is seen because of when the thrombus is more RBC rich thrombus, and it is sometimes told predictive also that if this is a hyperdense MCA sign is seen, then the thrombus is soft and there is chances of successful recanalization are very high, and it very much correlate with the site of occlusion. And CT angiography, it is very sensitive. It is almost comparable to DSA, which is considered gold standard for detecting vessel occlusion. But it is CT angiography is very highly sensitive and specific for large vessel occlusion. Okay. So this helps in detecting site of occlusion. Now the most important whether doing any perfusion is it will be fruitful or not. Okay, so that is if we have this this is only the normal CT scan NCCT clinical CT mismatch. If NIHS is more or equal to 8 and expect score is more or equal to 9, it is considered significant that significant salvageable tissue is present. Like in this case, NIHS is 16, expect is 10. So in this case, if we do recanalization, patient definitely benefit. In here, NIHS is 22 and expect is 5. So even if we recanalize this is already dead tissue. We are not going to regain this tissue. So patient will do bad. Again, in this case, ASI will be much better. Expect will be much better guide in detecting clinical and CT mismatch. Now, if the patient is presenting after 6 hours, then for decide whether we should do EVT or not, we need to get CT perfusion and penumbra information about the penumbra. CT perfusion usually it is calculated by Tmax minus regional cerebral blood flow. Like the same case, the hypodensity which was seen here, this is a CBV. MTT, we are seeing that this whole tissue is hypoperfused. Same thing if we correlate in the CT, if we see in CT angiogram or a CT perfusion, cerebral blood flow indicate more correlate with the final infarct volume than compared to cerebral blood volume. While in MRI it is different. In MRI, cerebral blood volume will be more correlating with the final infarct volume than compared to cerebral blood flow. So in this case, we use And instead of MTT, we use the time to max time to maximum of the signal intensity. And from here, with this minus this, we get the penumbra. And in this case, the penumbra appears to be big one. And so this patient will definitely benefit from mechanical thrombectomy. This is the final infarct size. Okay. So, as I told that CT can has answered all the 4 patients which we are seeking. Same thing we can understand from MRI. In MRI, the sequence which we are in acute stroke which we do, one is diffusion weighted, one is T2 gradient, flare, MR angio, and if required, we do MR perfusion. So first question, rule out hemorrhage. This T2 star gradient is highly effective, almost comparable to NCCT, and it only takes 2 minutes. In MRI, there is also one sequence which is called susceptibility weighted imaging, which is much sensitive than GRE. It is almost 3 to 6 times sensitive than GRE to detect hemorrhage, and it is also better than NCCT to detect hemorrhage. But the problem is it takes at least 5 to 10 minutes to acquire this sequence. So usually not not included in MRI stroke protocol. Coming to second question, the ischemic burden. What is in diffusion? Diffusion weighted imaging is a gold standard in detecting what is the ischemic burden, because it's a very early and very distinctly show the infarcted tissue. And same it is chordate lentiform internal capsule insula and MCA territory. And again, as I told, that 0 to 2 is very large. You should not intervene. 3 to 5, up to 6 hours we intervene. More than 6 hours, it's some patient we can intervene. And 6 to 10, all patient we can intervene. Coming to posterior circulation, MRI is much better than CT for posterior circulation. Expect score is 2 for pons, 2 for midbrain, 1 for cerebral hemisphere, 1 for thalamus, and 1 for occipital lobes. In posterior circulation, 8 or more expect score is considered somewhat favorable outcome. 7 or less is poor outcome, but it also depends on site of the occlusion. If there is only the occipital and cerebral infarct and still expect score is 6, then still it can do better. But if there is a complete midbrain of totally midbrain is gone, even expect score 8 will be patient will do bad. So, basis of diffusion weighted is that it detects cytotoxic edema. In cytotoxic edema, thus what happens that cells will swell. So, if the cells will swell, the movement of water molecules between the two cells it decreases. Also, the intracellular organelles are also break down, and so the restriction of water molecules within the cells occur. So, it is very immediate effect. So within up to 11 to 30 minutes, diffusion will start showing the changes, and because of that only, it is also very sensitive and specific. Also, we can determine the volume of the infarct core by simple calculation A into B into C divided by 2, and this is very much correlating with the final volume which we calculate with softwares. Important thing is B value is very much important. It's if B value actually we should keep 1,000 so we can detect the more B value like 3,000 it will detect very early changes, but that can be reversible. If we have seen the papers that there are reversible diffusion weighted imaging infarcts. So these are very high B value lesions and it may show reversibility. And important is it takes only 1 to 2 minutes to acquire this impression, and it is very much correlate with ischemic stroke severity. Now I'm coming for site of occlusion. As like NCCT, T2 GRE may also show susceptibility vessel sign, and if it's correlate well with the RBC rich clot. So in this case, if the chances of recanalization is very high, like in this case there is a we are seeing this susceptibility vessel sign M1 occlusion, and this patient will do better with easily recanalizable. compared to this patient, there is no susceptibility sign, and so these patients are. We can predict that what hardship we may come during recanalization. This just we can get the idea. Coming to MR angiography top, it is not as good as CT angiography. Also, it takes more time, but it is very high, sensitive and specificity for large vessel occlusion, and it is very helpful in making the decisions. So, we don't need to do contrast enhanced MR angiography in acute stroke. Only top image is sufficient for getting all the information. And finally, is there any salvageable parenchyma? So there are three things. We can calculate diffusion clinical mismatch. So clinical diffusion mismatch is if the NIHS is more than 8 and volume is less, diffusion volume as we calculated is less than 25 ml, then there is a significant salvable tissue present, and we should go ahead with the treatment. Now, diffusion flare mismatch. This is a very interesting thing. Flare will show the hyper intensity only when there is an increase in water content. It's like it is almost after 4.5 hours. It will start showing the hyperintensity. So if the flare hyperintensity is seen, it means that their tissue is now irreversibly damaged and it will not recover even after open the artery. So it is usually this diffusion flare mismatch is usually used only in such cases when we don't know the onset of symptoms or wake up stroke, and we want to decide that whether we should go with IV thrombolysis or not. If like in this case there is a large diffusion weighted imaging, in fact we are seeing, but in flare it is not there. So it means that this impact is less than 4.5 hours and we should give IVT. But in similar this case there is a diffusion image and this is a flare image. In both this means that this impact has already been almost in now developing subacute phase. So it is more than 4.5 hours. So this we should not give intravenous thrombolysis. And what is the MR perfusion? As I told, it is calculated by MTT, means increase in MTT, mean transit time, or decrease CBF minus low cerebral blood volume. So this case, we can see there is a diffusion defect. In CBV, this cerebral blood volume, it's same area we are seeing the decrease of CBF, and cerebral blood flow. It is more area. It is not very reliable into final impact. Or it is more area which is showing. And in MTT, this is a big penumbra is there, and it is we don't open the artery, and so this whole part will be impacted. So this very much helps in detecting penumbra. Another case, small impact which we are detecting in CBV. Also, we see that surrounding this low CBV, there is a increased CBV. There is because of collateral circulation, and if we not open the artery, then the whole part will infarct. So there is a big penumbra, and so we should open the artery. So this information. So clinical scenarios, if if there is in center there is only CT is available, then we should do NCCT, which will rule out hemorrhage and define aspect score. It will may give idea of where is the site of vessel occlusion, and also clinical CT mismatch will give somewhat idea that whether there is a salvageable brain tissue available or not. And based on this, we can start IV therapy. And what we should always and always don't take out patient without doing a CT angiogram, because we sometimes say that patient there is a normal CT, neurologist give the IV therapy and then take out patient, then wait for the effect, and then if it don't recover, then again patient is taken to CT scan and do CT angiogram. So don't do that. Just give the therapy within the CT scan and get the CT angiogram done with delayed phase, because it will help in detecting site of vessel occlusion. And if there is a large vessel occlusion, we should directly take to the cath lab. and it gives other information also. And if the patient is already more than 6 hours, then CT perfusion is available, then we should do it. It will help in suspected AIs with unknown time of onset and also with large vessel occlusion. This gives whether salvageable penumbra is present, and then we should accordingly decide for the further procedure. CT is not useful for lacunar infarcts. In posterior circulation stroke, we need MRI, and in also pediatric patient, MRI, MR angio is much better than CT and CT angio. Again, if MRI is available, T2 GRE will rule out hemorrhage. Diffusion weighted imaging will show the expect score, whether it is 6 or more, 3 to 5, or 2 or less. It will clinical diffusion mismatch will help to decide whether salvageable tissue is present or not. If the patient has wake up stroke, then FLAIR image will help to decide whether the wake up stroke is less than 4.5 hours or more than 4.5 hours, and then we can decide the treatment. MRA will show the site of vessel occlusion, and MR perfusion, as with CT perfusion, it will help to know whether salvageable parenchyma or penumbra, significant penumbra is present, which the patient will be benefited by opening the artery. In two scenarios, it is now new recommendation that in two scenarios, patient can be directly taken to the cath lab. One is if there is suspected AIS plus large vessel occlusion based on pre-hospital assessment, like race is greater than 4, plus patient is eligible for EVT. And in such cases, we should not waste time in going to CT, doing that. Patient is directly taken to angiographic shoot, where especially if flat panel CT AD is available, that is much more helpful. So patient can be taken on the cath lab, and CT can be done there only, and directly patient can be given endovascular therapy. Also, the subset of patient like like we in periphery from patient which are referred from the periphery and which are already established AIS with large vessel occlusion based on imaging or pre-hospital assessment, and which are eligible for EVT. We should not waste time in repeat brain imaging unless there is a patient is very much deteriorated or it is much transfer delays occur. We should directly take patient for in angiographic shoot for the DSA and SOS endovascular therapy. Thank you.
Thank you, Dr. Miran, for a extensive and highly informative talk. You'd like to invite Dr. Jayesh to introduce the next speaker. Dr. Bhattu.
Yeah, so now I would like to invite Dr. Batuk Diora. He's a professor and head of department at the Sion Hospital, Mumbai. He's a visiting consultant at Jaslok Hospital and Research Center. He's a very well-known vascular neurosurgeon. You can say hybrid neurosurgeon, so-called well-known figure in stroke management also. He's a course director of endovascular neurosurgery at Institute of Medical and Minimal Access Surgery, IMAST in Mumbai. He's performing very popular courses, I think 3 monthly. He's a course director for microneurosurgery workshop at Institute of IMAST in Mumbai. He's a faculty for endoscopic renal and spinal surgery at IMAST. More than 95 publications in national and international journal. He's at present the PG teacher and DNB guide also. Is well-known cerebrovascular neurosurgeon managing the disorders with both micro and endovascular procedures. And he is going to present the endovascular intervention in acute ischemic stroke technique, innovation and pitfall. I'm honored and privileged to present you. Batuk sir, please join us.
Thank you, Jayesh. Can you see my slides, Jayesh?
Yes.
So I will just keep it on slideshow mode.
Right, sir.
So thank you, Jayesh. Thank you, Dr. Matthew and Sachin, for having me here. So I am going to talk about the endovascular intervention in acute ischemic stroke technique, innovation, and the pitfall. We all know stroke is also a leading cause of death and disability. Almost half the individuals who survive more than 6 months after a stroke are dependent in at least one activity of daily living. Stroke is a huge burden in India. This is the data from India. Almost 2 lakh strokes cases are reported every year, and every 40 seconds there one new stroke is happening across the country. So it's a huge burden. We all know about the two types of stroke, and we are mainly concerned about the ischemic stroke. And around 30% of the ischemic stroke are because of the large vessel occlusion. And Yash, can you see my slides?
No, there is some.
Just a minute. Some problem. Yeah. Okay. Now.
Now,
Yeah.
yes.
Okay. There's some issues. Okay.
You can again share. You can stop.
Yeah. Okay. Now it's coming. It's coming.
Fine.
So ischemic stroke is a time dependent, and almost like 1.9 million neurons are dying every minute. So it's a major concern. If we see the treatment for acute ischemic stroke starting from 1947, when the anticoagulants were introduced, till the time we have a first IV RTPA for a thrombolytic therapy, till now, almost in 2015, we have a 6 randomized trial that significantly changed the treatment. We know over a period of many years, thrombolysis was a treatment, but we know there was a narrow therapeutic time window with the IV thrombolysis. Many times patients present late. And as my previous speaker mentioned about the contraindications in many of the cases, and poor recanalization of the large vessel even after IV thrombolysis. We know almost 60% of patients with the large vessel occlusion doesn't respond to IV thrombolysis. So there is a significant paradigm shift from time window to tissue window, from IV thrombolysis to mechanical thrombectomy. And the purpose is to save the penumbra. We all know about the penumbra. That's the area surrounding the infarct core, and we aim at solving the penumbra to having a clinical improvement. My previous speaker mentioned about the clinical and radiological correlation and indications for the mechanical thrombectomy, and the CT, especially the aspects scores, plays a significant role in decision making in these patients, along with the diffusion perfusion mismatch on a MRI-based investigation. These are the 6 landmark studies published in 2015, and they showed there is a significant improvement in the modifier Rankin scale of in the patients who underwent mechanical thrombectomy and those who are treated conservatively. So these were the trials were performed that the benefit of mechanical thrombectomy up to 6 hours. After publication of the Dawn and Diffuse trial, this mechanical thrombectomy window was extended from up to 24 hours. So now the endovascular treatment is a gold standard for the large vessel occlusion. Endovascular therapy has transformed the stroke from disabling disease to the potentially reversible emergency, and the mechanical thrombectomy is the standard of care. But though it's a powerful therapy, require careful patient selections. These are the indications that was previously discussed. No previous disability, occlusion of the either ICA or the MC, because we are talking about the large vessel occlusion, age of the patient, and of course we consider the NIHSS criteria and aspect score. So classically, the large vessel occlusion, especially the ICA, M1, and the very rarely proximal M2 and the basilar artery, and the time window we have is up to 6 hours that was extended following in a selected patients on the basis of diffusion and Dawn trial up to 24 hours. And my previous speaker mentioned about the role of CT angio, as well as the MR and perfusion diffusion mismatch. So there is a significant role of endovascular treatment in the form of thrombectomy. Under this category, there are some devices being used that applied constant force to the clot material at its proximal or the distal end and facilitate the clot removal. the proximal end force applied through the grasp-like attachment, where the distal end force applied via basket-like devices. This maneuvers results in the removal of the clot from the arterial systems, and we have a variety of devices available in the market. So if we talk about the techniques, we have 4 different techniques available. One that was started with the coil retriever thrombectomy, where the coil-like devices come from the microcatheter and that entangles the clot, and then slowly the clot is being removed. This method is not commonly used nowadays, but nowadays we commonly use a stent retriever thrombectomy approach and the direct aspiration. Many times we combine the techniques of aspiration as well as the stent retriever, that is called a solumbra. And many of the patients, we use a balloon guide catheter to flow for the flow arrest while removing this thrombus from the major artery. So these are the various devices being introduced for the mechanical thrombectomy from since 90 up to 2015. So this I have mentioned about the clot retriever system is the coil retrievers devices like the coil-like coil-like structures come out of this microcatheter and traps the clot, and that is slowly withdrawn from the major artery. Aspiration devices, the principle is it employs a vacuum aspiration to remove the occlusive clot in acute ischemic stroke, and these devices are suited for the fresh non-adhesive clots. They are having advantage of a fewer embolic material and decrease the vasospasm, because as soon as you put the aspiration device at the mouth of the clot, you can easily the clot and trapped at the mouth of the aspiration device, and you can entirely remove the clot from the arterial circulation. The device commonly used is a penumbra system and angiojet. Penumbra system, when it was introduced, it has a bore separator wire with a bulbous tip that operators continually advance and retract. That helps in the disruption of the attached clot, and then subsequently clot is being pulled out. The new technique that is called a direct aspiration first pass technique, where there is no other device being simultaneously used, and adapt aspiration catheter is placed at the mouth of the clot, and that is gently removed. So this cartoon shows how the clot of through the guide catheter, microcatheter is aspiration catheter is advanced up to the mouth of the clot, and then the suction is applied at the aspiration catheter, and then the aspiration catheter can be easily sucked out. So these are the various aspiration catheters from the different companies, and they are available in the various sizes and the lengths. So these are some of the cartoons showing the aspiration catheters. We commonly use Sophia Plus A68 catheter for the aspiration procedure, and these are the pumps, that penumbra aspiration system and Medtronic rapid aspiration device. The other commonly used mechanical thrombectomy device is a stent retrievers. So the stent retrievers are the self-expanding the stent which is deployed in the occluded vessel inside the thrombus, pushing it away and entangling it within the stent stress. The stent and the thrombus are therefore withdrawn back within the delivery catheter. So here you put a stent across the clot and wait for at least 4 or 5 minutes till the time the clot get entangles inside this the device, and then you can easily aspirate this clot through this catheters. So commonly used catheters that is available in the market is from the Solitaire from the Medtronic and the Trio from the Strykers. So this is the Solitaire X, the new devices that is there in the market that is commonly used for this thrombectomy procedure. These are the other devices from the various companies. There are a slight change in the configuration, or you can say the morphology of the devices. So there are higher chances of trapping, or you can say the entangling the clot. So can usually safely remove the clot from the arterial circulation. These are the various sizes. They are available in mainly 4 millimeter and 6 millimeter, and with the 20 millimeter 40 millimeter length. So the advantage of both these devices are patient doesn't require any pharmacological thrombolytic agents. As my previous speaker mentioned, you can directly, with the large vessel occlusion, once you conclude, you can directly take patients for a mechanical thrombectomy, and thereby you can reduce the chance of 9% risk of intracerebral hematoma following IVTPA. Also, IVTPA is a very limited time window. So when patients come beyond this time window, you can easily use this technique and do the mechanical thrombectomy. These devices fragment the thrombus and expanding the surfaces of clot and allowing the thrombolytic agents to be more easily accessed. And this provides a faster recolorization than the thrombolytics therapy, as I mentioned in the previous slides. However, there are problems associated with the procedures. There are technological difficulties of navigating mechanical instrument through the intracranial circulations. Many times the direct damage to the neurovascular structure may be because of this wire or the catheters or the devices, and sometimes the fragmentation of the thrombi causes a distal embolization to the previously unaffected vessels, and that may change the neurological condition of the patients. So the neurovascular procedures mainly has to be carried out in the neurovascular stroke unit, where the team of neurosurgeon, neurologist, or a neurointerventionist, as well as the radiologist, available. So if we see the procedural steps, many things has been discussed, but before you start, once you have taken a decision regarding a thrombectomy, patient family needs to be counseled thoroughly. Patient's family should be informed about the various trials, the results, and they should be clear in their mind. Opening of the vessel is a one thing, and the clinical improvement is a different thing. So many times you can open the vessel, but patient's clinical condition remains same. Also, simultaneously, patient's family should be informed about the possibility of the hemorrhagic transformation and additional surgery and the poor outcome associated with the procedure. So the procedure usually we perform through the femoral route and very rarely radial arterial access. From the femoral route, we put a femoral sheath, wide bore. Through that, we put a wide bore guide catheter that goes up to the proximal internal carotid artery, and through that intermediate catheter goes up to this cavernous carotid. And through that, either you can directly use the aspiration catheter or a clot retrieval system to remove the clot. And we always assess the post-recolorization angiography assessment, that is called a Tiki score. That is a thrombolysis in the cerebral infarct, that is called a Tiki score. So if there is no perfusion even after multiple attempts of thrombectomy, that is called grade 0 or no flow pass obstruction. Grade 1 is a minimal perfusion, bypasses through the one of the few arterial branches. And the grade 2 is a perfusion less than 50% of the vascular territory. So when the perfusion more than 50% or near complete perfusion, or sometimes complete perfusion, that should be considered successful. So TT 2B and 3 score is generally considered successful and associated with the good MRS score. So this is the video showing how the procedure is being performed. So as I mentioned, we put a wide bore guide catheter, sometimes in a balloon. Through that, the device, stent retriever device goes over the micro. First, you pass the micro wire through the clot. Over that, you advance the micro catheter. You remove the micro wire. Now you introduce the stent retriever device through the micro catheter. You pull back the micro catheter and open the device. So the stent retriever device will open inside the clot. Wait for at least 4 to 5 minutes till the time the clot gets trapped inside this retriever devices. And then if you are using a proximal balloon, then inflate the balloon and gently remove the retrieval system along with the clot. So care during and after the mechanical thrombectomy is equally important. The data shows recommendation is there. You can take the patient either conscious sedation or general anesthesia And the most important thing is the blood pressure management. My previous speaker has mentioned about this. One should have at least 140 systolic after recanalization, and before the recanalization, one should not aggressively try to reduce the blood pressure. I will show some of the cases. This was some of the cases like here, the 42-year male presented with the within 2.5 hours. He had a left hemiplegia. He had IV thrombolysis, no improvement, and he had a right MC occlusion that was open with the retriever system, and one can see there was a complete opening of the middle cerebral artery. So it was TP3 opening of the vessel. Another case, 20-year male, complete occlusion of the distal middle cerebral artery M1 segment after the temporal branch. And again, like we did the same thing, mechanical thrombectomy using a stent retriever device. This was a case of 52-year male patient who presented within 2.5 hours. He had a left hemiplegia. He also received tentricular, but no improvement. He had a complete occlusion of the right internal carotid artery just above its origin. There was no cross flow across the intercommunicating artery. So we did an aspiration through the occluded segment, and there was some flow. You can see there was some opening of this internal carotid artery. And when we injected just distal to the obstruction, there was a complete cutoff of the middle cerebral artery. So he underwent mechanical thrombectomy of the middle cerebral artery. So at the end, he had a complete opening of this middle cerebral artery. And in this patient, many times the large vessel occlusion having a tandem lesion. So almost 20 to 30% patients having a tandem lesion. So it's very, it's a difficult decision sometimes to do the stent or just do balloon angioplasty and perform the distal mechanical thrombectomy. These again one more case of 63-year male uncontrolled hypertension, sudden onset left-sided hemiplegia, and this is the CT angiogram showing a complete occlusion of the internal carotid artery on the right side. So in these patients, these are the various devices we have used to retrieve the clot. So again, there was a complete occlusion of the internal carotid artery at its origin, but there was very slow flow distal internal carotid artery. So in these patients, we aspirated the clot by putting an aspiration catheter at the mouth, and subsequently the microcatheter and the microwire was able to cross across the lesion, and just distal to the obstructed segment of the internal carotid artery, there was a very good flow. So this is the micro catheter run, show the feeling of the distal IC as well as the both the MC and the ACA. And in these patients, though there was a repeated occlusion at the repeated closure at the IC origin, we require a multiple. You can see in this image, we did a multiple angioplasty, and finally we had a very good opening of the vessel. You can see there is a good opening of the vessel as well as opening of both the ACA and the MC on the right side. So in this patient, sometimes it's a tricky decision whether to do the stent simultaneously or to call patient after a few days once the emergency situation is over. Many times there is a complete occlusion of the anterior cerebral artery as well as the middle cerebral artery. In this case, there was on the left side, AMC and ACA was gone, and we are open using a Solumbra method. Here we also use aspiration catheter along with this stent retriever devices. Posterior circulation strokes, as Milind mentioned about, we have a time up to 24 hours, and this was a case of a distal basilar occlusion that was successfully open. However, the patient had a poor clinical outcome. Again, one more case of the left MC occlusion. In this patient, we use aspiration catheter, and there was a very good clinical outcome after opening of this vessel. So as I was mentioned, many times we do futile attempt to open the vessel. Here there was a significant opening in the distal artery, but there was a significant stenosis of the anterior cerebral artery as well as non-opening of the middle cerebral artery. So in this patient, even after multiple attempts, we are not able to open the artery. Again, one more case, multiple attempts of the Solumbra as well as the stent retriever, the left MC were unfortunately not opening. You can see just temporal branch, one of the striate branches open and the rest of the middle cerebral artery was closed. So these procedures are having a technical challenges in the term in the form of like a tortuous anatomy. Many times, as I mentioned, tendon lesions, and sometimes there is a chronic IC occlusion and that can be misdiagnosed as acute. And presence of the collaterals is a key things. And when the collaterals are poor, usually patients require some sort of intervention. The concern is an intracerebral hemorrhage that sometimes you do not see immediately after procedure that can delay maybe next 24 or 48 hours. So patient family should be explained in detail about the possible consequences. Also, device-related problem, that is a subarachnoid hemorrhage, and the procedure technical problem related to the procedure is the fragmentation of the target thrombus into the distal vessels and the occlusion of the distal vessels, as well as sometimes the mechanical problem in the form of the detachment of the stents. Vessel perforation and dissection is a major concern because it's always associated with you are converting the ischemic stroke into the hemorrhagic stroke, and many times underlying stenosis or atherosclerotic problem causes the reocclusion of the vessel. There are a lot of innovations going in the vascular stroke therapy that includes the new generation stent retrievers and the aspiration catheters, wide-bore aspiration catheters that can be taken deep into the M2 or M3 segment of the middle cerebral artery as well as the distal intercerebral artery. Radial access is the boom slowly coming in the market, and more interventionists are trying to access this pathology via radial access. Also, AI-based imaging selection and the workflow optimization helps in decision making and selecting the procedures. And of course, there is a possibility of the remote robotic thrombectomy. So many times we use adjuncts in the form of intra-arterial thrombolysis, angioplasty, and the stenting, as I mentioned, and the use of additional protection devices as and when it's feasible. Most important thing, outcome predictors are the time to reperfusion, baseline NIHS score, and the aspect ratio, collateral status, and the successful TK2 B and 3 reperfusion. Future directions, we are looking at the extended time window and the image-based selection of the patient's role of a neuroprotective agents combined with the endovascular therapy and the establishment of the telestroke and the mobile stroke units and the robotic as well as the AI-guided intervention. So in conclusion, endovascular therapy is the cornerstone of large vessel stroke management. Continuous innovations are improving in the outcomes of these patients, and awareness of the pitfall is essential for a safe practice in the mechanical thrombectomy. Thank you.
Thank you, Dr. Batuk, for an excellent talk, showing practical aspects of thrombectomy. Our next speaker is Dr. Manoj Falak. Dr. Manoj Falak serves as the additional professor in Department of Neurosurgery and Gamma Knife at All Day Institute of Medical Sciences, New Delhi. He did his training from All Day Institute of Medical Sciences, New Delhi. He has worked there for more than 15 years. Falak is a versatile surgeon with specialized expertise in neuro-oncology, gamma knife radiosurgery, and complex spine surgery. His international credentials include fellowships from the American College of Surgeons and advanced training in biportal endoscopic spine surgery from South Korea. He's a prolific researcher and academician. He has 19 book chapters to his credit and over 60 publications. He has earned prestigious accolades such as the J.D. Modi Best Paper Award for the Neurotrauma Society of India. He will be speaking on surgery for acute ischemic stroke, surgical philosophy, technique, and evidence. Please, you can share your slides. Your slides are visible.
My slides are visible, Dr. Joseph?
You're very much and audible.
Right. So after comprehensive coverage, I've been tasked with a topic which is somewhat reserved for when the thrombolysis or the mechanical thrombectomy maybe doesn't work, or maybe the patient is out of the window period. So I'll be talking something about surgery for acute ischemic stroke, the surgical philosophy, technique, and evidence. So all of us know what stroke is, and there is no real class 1 evidence for surgical management. However, we still treat to prevent further neurological deterioration and prevent any untoward event. Most of the strokes are ischemic in nature, and malignant MC infarction is actually defined in different studies according to area of involvement. But essentially, it means that the neurological deterioration is quite rapid because of the effects of cerebral edema. So we must understand, or rather we must revise the Monro-Kelly doctrine, which says that cranial cavity is a rigid sphere. It is filled to capacity with non-compressible contents, of which CSF, blood, and brain are the most important ones, and the intracranial space is constant. So what happens is, once there is some edema, the other two contents will be displaced or the pressure will rise. So that is the basis of herniation, and maybe the autoregulation is also lost. So essentially, the cerebral perfusion pressure is affected, and the patient goes into another cycle of vasogenic and cytotoxic edema, which is further propagated because of the loss of autoregulation. So if we see the pressure volume curves, we will realize that the intracranial volume and the ICP relationship is actually not linear. It is hyperbolic in nature, and compliance actually decreases when volume increases. So at lower volumes, you'll see the compliance is quite high, 0.62. At higher volumes, it is just 0.14. And if we plot a logarithmic graph of this, so we can come to a pressure volume index. And the pressure volume index is essentially a volume which is needed to raise the ICP by a factor of 10. So when the pressure volume index goes beneath 13 ml, that is considered abnormal. So as I told you, the malignant edema will cause raise in ICP and a poorer outcome. Of medical treatment, we can give diuretics, we can give osmotic agents, we can do hyperventilation, and eventually decompressive craniectomy as the last step. So we do a removal of a large amount of bone flap and to create a compensatory space to accommodate the swollen brain. So there are landmark trials for decompressive craniectomy: Destiny, Decimal, and Hamlet. The three trials, they were randomized controlled trials done in different countries, and the Destiny was done in 2007. It was a prospective multi-center trial which had the first endpoint as mortality at 30 days, and a significant result was already reached by the time 32 patients were recruited already. So the survival actually increased after decompressive craniectomy. And when we talk of decimal trial of 2007, it was again a multi-center RCT, and amongst the 38 patients randomized at 1 year, there was a significant reduction in death after craniectomy, and the MRS also increased. And similar results were seen in Hamlet 2006, which was stopped prematurely because it was unlikely to show a statistically significant result, and reduction in case fatality was seen. So when we see the pooled data of all these studies, we find that surgery was beneficial in all age groups, whether above 50 or below 50, in presence of aphasia and more than 24 hours, ideally within 48 hours, and no significant subgroup treatment was seen. Early decompression was found to be helpful, and the probability of survival was seen from 28 to 80% increase. So eventually the pooled analysis came to a conclusion that in patients aged less than 60 years with malignant MC infarcts, decompressive surgery done early within first 48 hours reduces mortality and increases the number of patients with a favorable functional outcome. So now let us talk something about decompressive craniectomy. So this image shows the approximate area supplied by the ACA, MCA, and PCA. So if there is a malignant MC infarct, essentially we want that the brain which is likely to undergo swelling has to be given some space so that it swells outwards, not inwards, right? And then the surgical technique of decompressive craniectomy comes into the picture, where a large frontotemporoparietal craniectomy is recommended, around 12 by 15 centimeters in dimension, which is usually done in trauma settings. And most important is doing a thorough decompression from temporal base to temporal skull base, right till frontal midline. I mean, 1 centimeters or 2 centimeters from midline. We do a wide dural opening and we do a expensile duraplasting to accommodate the swollen brain. Small craniectomy will have a counterproductive effect because the veins might often get compressed at the edges, and no routine lobectomy is recommended. So the skin incision is very important. You have to plan an appropriate skin incision so that you are able to do a large craniectomy, and you have to dissect the skin and the underlying pericranial flap so that you can use it later as an autologous graft. We routinely do a measurement of the amount of bone we are cutting. So before making burr holes, I mean, this picture was taken for representative purposes, and we make multiple burr holes because often these patients are quite old in age. They are more than 50, around 60s. So the dura is often stuck. So as per standard neurosurgical teaching, you have to make a lot of burr holes, and the prominent one being at the temporal base and the key burr hole, frontal key burr hole. And then you have to make a craniectomy, and this image actually shows the taking out of this sphenoid ridge, which is essentially trying to make the anterior cranial fossa and middle cranial fossa as a continuous compartment. And earlier people used to do tentorial sectioning also, but nowadays it is not being done because of the difficulty of access and not significant changes in results. So once you have done a craniectomy, the bone work, you open the dura in a stellate manner, and then the pericranium is taken up as a graft to allow for the expansion of the dura. And essentially what you are looking for is that this picture actually shows that this patient has an infarct, and once we do a craniectomy, the brain goes outside. It will not go inside, or it will not exert a downward pressure to cause a transtentorial herniation, right? And if we look at the coronal images also, we must realize that the decompressive work, the bony work, has to go right till the skull base. But I mean, if this procedure is such a great procedure, why we don't do it for every patient? Because there are a lot of complications, not infrequently associated with this, but there are. So there can be external cerebral herniation, which you saw in the previous picture. There can be a hydrocephalus, which is forming in this patient. There can be a subdural hygroma at times. There may be a syndrome of the trephind with a sunken flap and seizures. So when we talk of our own experience, we had a study of 60 patients with 36 in surgical group and 24 in medical management. We found that the cumulative risk of death is less in the surgical group, with the absolute risk reduction of 45%. And decompressive hemicraniectomy leads to markedly improved survival and better functional outcomes. The benefit of surgery in motor and aphasia recovery is also progressive, and the age is not a predictor of outcome, so it has to be offered to every patient. I mean, the international studies, they restricted preferably to 60 years of age, but in our study we found that it can be offered to any age group. So something controversial now. What happens if the patient is not a candidate for thrombolysis? Or maybe a patient underwent thrombectomy, but it failed, or we were not able to go across. So surgical thrombectomy is not a first-line therapy. People in past have tried bypasses in 70s and all, but they did not meet with very favorable results. However, in acute settings, so the current indications are that if the endovascular therapy thrombectomy fails, then it can be used as a rescue option. A hard calcified embolus may occur in a chronic IC occlusion, as my previous speaker told us, but that can be tackled with this: a complex anatomy or dissection, need for a simultaneous bypass for other indications, and selected early window large vessel occlusion. So there was a RCT which was published quite recently, and they actually enrolled patients with failed mechanical thrombectomy and achieved almost 75% recanalization and good outcomes in almost 60% patients. So it may be considered as a safe third tier rescue option. So that is the status of surgery in acute ischemic strokes. So there is a definite role of neurosurgical intervention, more in terms of decompressive craniectomy, which actually reduces mortality. And eventually, a microsurgery may be a safe third tier rescue option in selected patients. Plus, the endovascular interventionists, they are not available round the clock or everywhere. So I visited a center, international center, quite 2-3 years ago. There they had a practice that since the interventionists were limited, the neurosurgeon on call, if at all, he was not trained for the intervention, so he would do these kind of procedures. So
Thank you, Dr. Manoj, for that, for your excellent talk. Now, I would like to invite our panelists to give their expert comments and ask any questions to our speakers.
We are supposed to ask questions to the speakers?
Yeah, you can ask, or you can give your expert comments.
So yes, thank you so much. First, thank you so much for those awesome talks. And Deep is here. I don't see him, but I think he's around. Deep does. So, however, anyways, so we had the recent publication of the 2026 guidelines in the International Stroke Congress about the stroke guidelines by the HASA. And, the notably in the management of acute ischemic stroke, the entire trajectory from one of awareness to the transport, the triage, the acute management, the preventive aspects, the entire thing was that the whole tapestry has been covered with certain emphasis essentially in the stroke guidelines, which have been just kind of published. Was one, they had a lot of emphasis on the mobile stroke units, which, personally, I would still believe that it's sort of a white elephant. But then, and down south in Coimbatore, the original experience was not really exalted in any way. Said that, the ICMR venture with Dr. Jairaj spearheading that program in Dibrugarh in Assam and Tejpur, the mobile stroke units did some good work. Most important is that they could establish the stroke units and also the awareness. Those are all the spin-offs which happen when you get in something big, and then you have to have that entire stroke chain. Otherwise, it doesn't work. But in the guidelines now, there's a lot of emphasis on the mobile stroke units. That was one. And the second emphasis was a lot on pediatric acute strokes, and a big focus on the endovascular treatment and the guidelines or the treatment algorithms for pediatric ischemic strokes, where you now have guidelines of how much to intervene and how to intervene in terms of endovascular or mechanical thrombectomy. So those have come as guidelines. Otherwise, pediatric strokes was one big, a black hole where you didn't really know. And that kids are not small adults. So, that transformation backed upon adequate science and coming to a class of evidence as big as 2B and 2A. So it was big. And the third focus was on the usage of tenictic plates. So in that regard, I think it was, although they did not acknowledge, but I think it's a make in India, proud moment for us, because India was the first one to actually, say yes to tenictic plates. And so although the dosage now is no longer 0.4, it is 0.25, and there is no sort of In some areas, there's no clinical equipoise. And in some areas, there is a clinical equipoise that it exists equal, if not bigger in certain areas. So it's a serious competitor to alteplase. So that's come as a guideline. So that is big again. In various caveats of acute ischemic stroke management, whether the time window frames are within 4.5 hours, 4.5 to 9, and beyond that, and as well as large vessel. So those time window frames as well as the guidelines have also got a big focus. And then we have the focus then slightly shifted towards the management of swallowing. So now, a lot of times as swallowing, we say, oh, do physiotherapy. So a lot of times it is especially say you have medullary strokes or posterior circulation, lateral medullary, small little stroke and big deficits. And aspiration is such a big bugbear in those outcomes. So in that, they've gotten a rehab program with the ENT and stroboscopic kind of electrical stimulation of the larynx and to help in swallowing. So that's again come as a guideline. Why I'm telling this is that these have always been sort of relegated to a realm which was pretty gray. It was practiced somewhere, not practiced somewhere, and certainly it's not practiced widely, at least in our country. So those were some of those guidelines. I don't want to go through the whole thing, but these focus points have been highlighted, and I think that's out of all this, I think a big win for us is a global recognition of tenecteplase. And the dosage is 0.25 milligram per kilogram body weight. I mean, that's my contribution here.
Fantastic. Matthew sir, you are on mute.
I had a question for Madam. Whom do you think should man a mobile stroke unit? Should it be a general practitioner, or who should man a mobile stroke unit?
I think that's an excellent question. So I believe that the stroke management is a team. So you can have a leader up there who can be, sort of lead from a front, but the management is always a team. And now we've actually shifted towards physician programs because we call them stroke physicians. Because how many neurologists do we have? I think even a figure of 4,000 I'm not 4,000. I'm saying how much do we have? I don't know how many we have neurologists across. How many are you neurosurgeons across the country at this point?
Neurosurgeons approximately 5,000.
5,000. So we are less than you. So maybe around, so that for a 1.4 billion population, we probably will have another Australia added to us in the next 1 decade. So, we will never equate in terms of what could be. And then one stroke unit, the comprehensive stroke unit for, for million population, there are those, the geospatial international guidelines will never match them. And I don't think we should gear up to manage. I don't think we should be producing more doctors. The expertise has to match up towards the quantity. And in that, the physicians have come into the umbrella. So therefore, a stroke physician is well equipped. And the team leader in that, like, mobile stroke unit, you basically have a tele. The team which is there within the mobile unit is not a neurologist. It's just a physician. Or it can actually be a trained nurse and a paramedic, except that you have a CT scan there. And actually the information is the transport is tele, so that you are equipped with the information to deliver the thrombolytic drug there. Most often they don't. They actually try and bring it. But ideally, you're supposed to deliver it there. And the other thing is also the blood pressure management, especially in ICH. Now we have Interact 4, which sort of said yes, at least in a CT, you find a bleed, then you drop it down to less than 140/90. Now that's been established and it does make a difference. So these kind of acute interventions can be done by a paramedic and a trained nurse and not necessarily a neurologist. So in the van, it is probably at the most a physician and this. And there in the nerve center where there is a teletransport, there probably you need at least a stroke physician, if not a neurologist, just like you have a cardiologist who's doing this is being replicated for a brain attack. So your question is validated, sir, but I think in our country, we're not going to position neurosurgeons, neurologists. I think we should have trained physicians who can man this.
Thank you. I would like to invite Professor S.K. Gupta to give his comments.
Evening. I think we have had excellent lectures from people who are really doing good work, and Padma has summed up everything. So there's not much to add. Just had one question for the interventional people. Has anybody experience in using stents in the middle cerebral artery, or is it being used?
Batuk sir, you are mute.
Yes, sir. It's a good question, and many times it's being used either in a middle cerebral artery or in the basilar artery. Even after repeated opening, the artery getting repeatedly blocked, then there is no other alternative except to put a stent across the stenotic segment. Yes, sir.
Okay, I think yeah. So because that's not very widely being used, I think it's still in the upcoming. I've heard about it. Has it been authorized to use in India? Do
Yes,
we?
sir. Yes, sir. We are using regularly as and when required. As I have shown in the two cases, like many times in the internal carotid artery occlusion, it's the main culprit is a significant stenosis, and even after multiple angioplasty, it gets blocked. There is a possibility you put a stent across the stenotic segment.
Yeah,
Yeah, it is being commonly used, sir. Yeah.
just one small comment. As Dr. Padma said, pediatric stroke is an important thing, and one of the most common causes is moya moya. I think that is also a thing sometimes goes unrecognized. So all the major centers across the country are not doing surgery or recognizing moya moya, but there's a common cause which is often missed. So that has to be managed. Otherwise, I think this has been a good session. I have nothing more to add. So as a neurosurgeon, I think if it comes to a infarct, that means we already lost the battle. So we should intervene before it becomes an infarct. That's the main important. And that was the crux of the today's talk, I think.
Thank you. Thank you, Gupta sir. So I have a 2-3 question in my mind. This question is open for all the panel. One is, so we have talked so much about the large vessel occlusion, but what about the small vessel occlusion? Are there any new guideline, or whether is there any new drugs for that? That is number one question. Second, we have, as a neurosurgeon, we have called when there is a hemorrhagic transformation, or to prevent the hemorrhagic transformation. There is many questions whether we should use new Klaxen, when to use Klaxen, when not to use, that there is a high risk of hemorrhagic transmission. Do not use Klaxen, after surgery or after large vessel opening by vascular intervention specialist. So these are the two questions. If anybody can highlight on that.
Can I take it?
Yes, yes.
Yes, madam,
So
please.
one is that very important question of a small vessel disease. Okay, we call it a small vessel disease. So one is in an acute stage, the other is a prevention. Now, cerebral small vessel disease is the subtype, which is actually parabola. It doesn't have just a conventional risk factor in terms of hypertension, diabetes, atherosclerosis, what have you. So in a small vessel disease, the perfusion matters. And so therefore, the intravenous thrombolytics in its usual course of guidelines come in. There's no controversy there. Do we have any new drugs? Yes. The other medication which is being actively pursued is retiplase, which may come, which may not come. In fact, it is within the Chinese stroke guidelines. And many a time when it is in another, Far East guidelines, by the time the West actually accepts and comes down to us, it takes some time. But that's a good lytic drug to watch out for. But more importantly is in the prevention aspects, whether it is a small vessel disease or even an embolic event, in say in ESIS, which is not actually lacunar, and they're all small vessel, could be also a large vessel, but a presumed embolic. You have the factor 11A inhibitors, which are coming up in a big way. So the Anduxian and all those trials which have got now published. Now, Anduxian will come in when you want an effect which is bigger than an antiplatelet, but you want a hemorrhagic risk lesser than an anticoagulant. That's where they come in. And I see a lot of promise for this factor 11A. Yeah, it's not a guideline, but that's my personal take on this, that that's one thing to look out for, especially in this group as such. You know, but then in terms of opening up a vessel, when it comes to when we have all the trials of, I mean, the interventionists can correct me on this, but the distal, the MEVOS and the distal vessel occlusions have not found a level of evidence right now to intervene. All the latest trials have not really, there is definitely still not a clinical equipoise. There's a problem there. So probably, I'm sure they will go in with a better infrastructure and better expertise. We need those little malleable, probably your wires and your, hardware to be able to be pliable into this cerebral circulation. But at this point of time, your safety factor is offsetting your outcome. So your MEVO, DEVO don't have. So I think small vessels, which are, beyond any large vessel kind of thing, you don't have anything happening exciting at this point of time, still in the realms of research. Prevention may, you're getting some very interesting molecules up there.
Absolutely.
I had a question to Dr. Bhattu and a small comment about what Madam said about small vessels. Do you think the risk of intervention in a small vessel is worth? Because very often the deficit that a small vessel is likely to produce and producing a bleed, suppose you're a little late, or a direct intervention after the window period. Do you think that risk is worthwhile? This is commodities for Madam.
So as Madam mentioned about, in case of the large vessel, there is a significant thrombus load in the artery, and the artery size is sizable. So the whatever catheter you are using to plug the clot inside the catheter or in the retriever, it's beneficial. But in case, as Dr. Padma mentioned about, there are trials, but the trials are futile, and they have shown no significant benefit of opening the distal, or you can say the medium-sized arteries. There were trials conducted, but they were not you can say the level 1 evidence what we have for the large vessels. And second thing, when as you go distally into the small size vessel, again the bore of your catheter will be smaller, and again you have to you put a, because in case of an intervention, always wire will be ahead of the micro catheter, so you have to put a wire distally inside the small vessels. So there are a chance of rupture of the artery or a dissection with dealing with the small vessels, or you can say medium-sized vessels.
Okay, Dr. Bhattu, once you do, suppose you are forced to put a stent into an MCA vessel or into the basilar. Basilar, probably you'll be putting a perforated stent or a flow divert. How will you manage the anticoagulation after that in the background of an acute stroke?
So that is a very tricky, as also Jayesh mentioned about the rule of Clarkson. In fact, the endovascular procedure is being performed under the cover of heparin. We always give a heparin. No doubt, we do not give aspirin for maybe next 24-48 hours. But if we are putting a stent, definitely we have to give a antiplatelets medication for these patients. Yes.
Okay, if suppose you
one
result in a
of-
bleed.
Yeah.
So
So see,
one of the ways to actually prevent a bleed is just control your blood pressure. And it's also been said now that the last guidelines also said that don't drop it also very much. And even during the intervention period and post, now you don't want to go less than 130/80. You're putting that sweet spot is 130/80 to 140/90. Earlier, you always, post perfusion, you wanted it to really go down. So the last guidelines now, which have said that, yes, you shouldn't have hypertension, but you shouldn't have a hypotension either. So actually, the blood pressure is a very tricky period there, which probably will help your better outcomes as well as prevent a bleed.
Madam, one aspect I just wanted to ask you. In peripheral intervention, in limbs, people very often use hyperbaric oxygen after a thrombectomy. It's extensively used in Japan and all. It's almost a rule. Why has that not been used in acute ischemic stroke in the brain?
No, but hyperbaric oxygen, there were trials which were pretty old, and then we had normobaric trials. In fact, normobaric oxygen in acute ischemic stroke was once, promulgated from Mass General. And Anish single group, in fact, had this MR studies of an acute stroke. They actually mapped out the diffusion weighted, the so-called volume. We know now it's dynamic, but at that point of time, they said that would be sort of reflective of a core. And then they did normobaric. And there's a high flow oxygen, but a normobaric. All those trials, sir, have become negative. All. And in hyperbaric, it was harmful. So therefore, that has been, unfortunately, you see the brain, we don't have a muscle in the brain. That sort of actually differentiates the heart and the limb. But when you brought in the limb and the peripheral disease, one important molecule you just suggested, silastazole, that's coming up in a big way. So ultimately, we may be coming up to, giving silastazole with aspirin and not really aspirin and ticagrelol or aspirin, prasugrel, aspirin, clopidogrel, which is most famous now. Because again, lessening the bleeding risk, because the biggest bugbear in the brain of any intervention is a bleed. So that may be coming up, sir.
Sir, I want to add something regarding MIVO. So we have seen that all the majority of the trials which have happened in MIVO has been negative, but there are case reports, and in my experience also, sometimes what happens that there is a single sylvian artery occlusion, and patient will have dense deficit hemiplegia. And in such cases, if we open the artery, and then patients are doing very well. And another thing in MIVO, the told that there is a chance of vessel perforation. The more problem is that when we go into the Sylvian area and when we pull the stent retriever, then that the whole that part of the MCA is not supported by dura and anything. So the surrounding vessels, it is almost they will rupture. So it is not more than wire perforation. We have seen some. I have seen two such cases. There is small bleed which will be self-limiting because when we pull the whole structure, we can see it is pulled. So that is a that is issue. Thank you.
Just to confirm it, Dr. Padma, still in the new guideline, there is no role of anti-epileptic prophylactic, right?
Absolutely, you're right. But I would always say that guidelines are guidelines and the practice is practice. And I do see now I'm in the private sector, and I do see a lot of prescriptions, especially after an ICH. There is a prophylactic anti-epileptic there, but whenever there is a lobar bleed in the brain, hypertensive lobar bleeds, and those bleeds which are sort of near cortex, subcortical, I'm also scared. And there is an evidence which says that a short-term anti-epileptics will sort of protect. And actually, when you look at, there were animal studies which actually said when you're giving phenytoin, there were neuroprotectant in those situations. So we don't have large trials. And in CVST, cerebral venous sinus thrombosis also, prophylactically, a lot of people are on anti-epileptics. So I would leave it to your discretion. But at the same time, if you're little bleed somewhere, and especially a small little infarct, you have a lacoon, is an acute lacunar infarct, you shouldn't be putting them on prophylactic antiepileptics. So judgment is important. So guideline, unfortunately, cannot be, across the board. So the sweeping statement is don't, but there are caveats where prophylactic antiepileptics, I think, are important.
Fine.
Sir, I want to ask one question to Manoj, sir. In our scenario, we usually see that if there is a posterior circulation stroke, and we told and tell neurosurgeon to intervene. They usually don't. They will say that now this is poor, so we should not intervene. So, what is the time period when you will do decompression in posterior circulation stroke?
No, rather, it's not time period. It's so the current 2026 guidelines which have come up for AHA, they also say the same, that if the patient is having a hydrocephalus or something, you can actually offer a ventricular drainage for the patient as a temporizing measure. And is still, if the patient doesn't improve, then a decompressive may be added. And if the volume of the infarct is already 35 cc or something, straight ahead a decompressive can be done for the patient. However, having said this, a patient with a GCS of 3 usually we don't operate, because we presume that he has already herniated. And if at all some chance has to be given, we usually put up a EVD and check whether the patient turns or improves, and then a decompressive may be offered. So that is the practical way how we handle it.
Dr. Manoj, can I ask a question to you?
Yes.
So you have presented your data about the decompressive craniotomy for MCA malignant infarct.
Yes.
Now I just want to ask on one scenario. In that case, a patient is having a MCA territory infarct. The patient doesn't receive any IV type, IV TPA or a mechanical thrombectomy. That is one scenario, and patient require a decompressive craniotomy. And second scenario, patient received either IV TPA and mechanical thrombectomy that fail and then develop a malignant cerebral edema. Outcome difference you have noticed?
Not much. I mean, recently we did similar kind of patients. I mean, the first scenario which you told, we usually get those kind of patients at our place, because often patients are not able to report in time.
So being a neurosurgeon, I do thrombectomy, and subsequently when we need to do the mechanical decompressive craniotomy, we saw some sort of a poor outcome in this patient when patients underwent some sort of a mechanical thrombectomy or a IV TPA and the decompression subsequently.
Right. No, usually, I mean, I have not seen it. I tend to delay these kind of cases for at least 24 to 48 hours, because often these patients are on aspirin and whatnot. So earlier we had a bit of reluctance. Nowadays, we usually do it as soon as possible. I mean, if the patient is deteriorating, we'll not wait.
Just want to add, Dr. Manoj, did you also same experience that in young patient with large vessel infarct, MCA territory infarct, which is not, mechanical thrombectomy has not been done and it's out of window, just early decompression at the age of when there is a ventricular effacement, give a better cognitive outcome, better chance of, improvement and recovery after decompression?
No, not really. I mean, my own personal experience, I haven't seen many young patients coming to us. The ones who come to us, they are usually investigated for the cause of infarct. Early, we don't do unless the patient is deteriorating or there is some sort of evidence of mass effect. We do not do it as a prophylaxis. We do not do it as a prophylaxis.
I just wanted to add the outcome of whenever we have done a decompressive craniotomy for a young patient, I have always felt that the outcome is totally radically different. Their outcomes have been extremely good, unlike the adult patients who have had a decompressive craniotomy. I just wanted to ask a question to Dr. Manu. Do you think when decompressing the posterior fossa, just bony decompression is enough, or if you have large volume of infarcted tissue, removal of the tissue would be beneficial? Because the amount of decompression you can give in the posterior fossa is comparatively limited.
No, we usually do the bony decompression. We open up the dura and we close as soon as possible. We do not even try for a duroplasty in posterior fossa, because the amount of tissues which you can get is limited. Then you have to put additional incisions, increases the surgery time, and a lot of other issues. So, and the results have been, I mean, at par with even patients where we have done duroplasty in tumor cases more so. Compared to the patients for stroke, the results are more or less same. So for posterior fossa, we really don't push for the watertight expansive duroplasty.
Fine,
Anything more, Dr. Jayesh?
No, I think time is 6:05.
Okay. I think we can complete our webinar today. Thank you. I have to thank all the speakers, all the participants, our panelists for such an excellent session. And special thanks to Sachin for coordinating the session so well.
Thank you.
Thank you. Thank you.
Thank you.
Thank you. Good evening.
Thank
Thank you. Bye.
Sachin.